Every system hides its incentives in plain sight. In elder care, the question is not only who gets care, but who gets paid when care fails. For-profit nursing homes run on a simple equation: maximize occupancy, minimize labor, and stretch reimbursements. The hidden margins appear when quality drops and oversight stays weak. The ownership structure is often engineered for distance. Real estate, operations, staffing, and management can be split apart, turning accountability into a maze of legal layers. That maze matters because when something goes wrong, each entity blames another. Meanwhile, the resident is left with the consequence of institutional design. Staffing is the first pressure point. Fewer aides mean fewer rounds, slower response times, and more missed care, while labor savings quietly improve reported margins. Food, supplies, and basic maintenance become easy places to squeeze. The public sees a building, the ledger sees line items to be cut. The business model rewards occupancy more than outcomes. Beds filled by Medicaid or private pay generate cash, but staffing quality does not always rise with revenue. This is where hidden margins emerge. Management fees, rent payments, and consulting charges can drain operating income before regulators ever inspect the books. Regulatory capture thrives on complexity. Agencies often inspect paperwork, not the deeper financial architecture that determines whether care is actually funded. Even repeated violations can become manageable costs of doing business. When penalties are small, some operators treat citations as a predictable expense, not a warning. The human cost is measured in falls, infections, dehydration, and preventable hospitalizations. Each event exposes the gap between care promised and care delivered. Short staffing is not an accident when wages stay low and turnover stays high. The system can become a revolving door designed to suppress labor costs. Private equity often enters with a playbook of leverage and extraction. Debt service rises, operational flexibility falls, and the resident becomes the source of repayment. Heavy borrowing can turn the facility into a financial hostage. Instead of investing in staff, cash is redirected toward lenders, owners, and transaction fees. Related party transactions blur the line between care provider and profit machine. The operator can rent its own building from itself and call it normal. Inspection regimes often favor visible compliance over financial truth. A clean hallway can mask a hollowed-out staffing model and a drained operating budget. Follow the reimbursement trail and a pattern appears. Public dollars flow in, but layers of ownership can siphon value before it reaches bedside care. This is not simply a bad actor problem. It is a systemic flaw, where the incentives reward financial engineering more than dignity, patience, or time. Residents are getting older, frilier, and more medically complex. Yet many facilities remain built around old staffing assumptions and thin operating margins. The people inside the building absorb the pressure first. Exhausted staff make harder choices under impossible conditions, and those choices ripple into harm. Medicaid often funds the majority of long-term care residents. That makes state budgets part of the story, and weak oversight a fiscal liability. Policy itself can be shaped by the industry it is meant to police. Lobbying, revolving doors, and political donations help preserve favorable rules. Some chains make more from real estate than care. When the building is a profit center, quality investment competes with shareholder extraction. Families rarely see the hidden ledger. They see a bill, a promise, and a brochure, but not the intercompany charges or debt structures behind it. Quality metrics can lag behind reality. By the time the data confirms trouble, residents may already have lived through the consequences. Deferred maintenance is another hidden cost of extraction. Small failures accumulate until they become emergencies, and emergencies are far more expensive than prevention. The institutional design often places decision-makers far from consequences. Those who approve budgets do not wake up to the alarms at 3 a.m. When care collapses, costs do not disappear. They move to hospitals, taxpayers, and families, making for-profit neglect a hidden burden on the wider system. Financial reports may look healthy while day-to-day care deteriorates. Profit can rise through leverage and cost-cutting even as quality indicators quietly fall. Whistleblowers often reveal what the official records conceal. Their documents expose patterns of understaffing, retaliation, and financial maneuvering. Settlements can punish a case without reforming the system. If penalties stay below extracted profits, abuse remains economically rational. Real reform starts with transparency. Ownership should be clear, related party deals should be visible, and staffing rules should match patient need, not industry convenience. Public pressure matters because these facilities operate inside a social contract. Communities deserve to know whether public money buys care or merely subsidizes extraction. The branding is always warmer than the books. That gap between image and ledger is where the real story of abuse begins. Elder care should be a public promise, not a profit loophole. Until incentives change, the most vulnerable people will keep paying the price. If we want different outcomes, we must redesign the system itself, not just punish the latest headline. Subscribe for more.